And I really appreciate that disclaimer, Janet, because one thing that I would like to use this space for is creating that dialogue and perhaps a community of support, because we are diving into a very heavy topic. Suicide in physicians and medical trainees is something that has been really accompanied by the culture of silence in medical enterprise. And I think there are lots of things that are bigger than us, including systems in which we operate. But one thing that we can do as individuals and as a group of professionals that hopefully supports each other is to be able to just be there and be honest about our thoughts and feelings. So again, like I said, I encourage you to use this space for that purpose. And I also want to say that I would love to know who we have in the audience, because you know, it might be you're a seasoned medical professional, it could be you're a medical student or a resident. I would love to know who I'm speaking to, so I also can cater a bit of a content to your specific needs and interests. And throughout this conversation, I'll be posting some questions for you, and I hope that you will use the chat to answer them. So with that, let me start. My name is Viktoriya Karakcheyeva. I am a foreign trained medical doctor, was trained in Ukraine, came here. My path took some twists and turns, and I landed up doing psychotherapy. And I'm currently working as a behavioral health director at Resiliency and Well-being Center. And I see someone raised their hand. Is there a question that we have? Janet, if you can help me with those. Okay. Dr. Bose. Please.
Okay.
Yeah, I think Dr. Rosemary Bose joining us. Welcome. And I thought she raised her hand, and maybe she wants to ask a question. Yes, here she is. Please. If you can unmute yourself. Yes, perfect. Yes, Dr. Bose, you had a question?
Chat is disabled.
Oh, chat is disabled.
Oh, okay.
Okay, Janet, can you help us with that?
Yeah, sure.
Ability.
I didn't realize you could hear me. I thought I had to do it over the with this chat. Maybe it doesn't matter if you will allow people to
your hand. So thank you so much. And yes, if there are things like that you would like to know about them, of course, we're in a high-tech world these days, but sometimes technology betrays us. Alrighty.
Everyone should have access to the chat now.
All right, perfect. Thank you so much. So with that in mind, I want you guys to look at this picture of the white coat that I posted at my first slide. And the title for today's talk is The Price of the White Coat. I think the white coat has a very special meaning for everyone that wears it. And I want you to think about, what does it mean to you? And it could be a lot of wonderful things, but it could be things that are challenging. It could be things that are, you know, really hard for you to endure. So try to be as honest as possible, because we're trying to make this conversation real. One thing that I'm going to tell you about myself and what made me interested in the topic is that I grew up in a family of physicians. There are 3 generations of doctors in my family, and everyone is a psychiatrist. So you can imagine what it was like to grow up in a family like that. So I've seen it all. I've seen the good, the bad, and the ugly. And I also seen how my parents, my grandparents were really trying to navigate all of the challenges of profession. I vividly remember one of the conversations that I had with my dad, who at the time was running crisis department at our regional hospital. So for 30 years, he has been working with people who attempted suicide, and trying to help them to rediscover the meaning of life and the colors of life. And we had this heart-to-heart conversation, and he told me, you know, it gets lonely out there. You got to make sure you take care of yourself. And as I'm talking about it, I'm sorry, I'm getting emotional. I can still see his face. And that look. And at the time, I was this young, impressionable girl that was like all excited about being in medicine and being the savior of the world and a healer. And like, what are you talking about? But then later in life, I understood. So my first encounter with suicide happened when I actually was a medical student. And I had a wonderful professor of pathology that we all loved. He was the sweetest guy. He always had this very sad look on his face, but very nice smile. And then one day the rumor spread around the university that he took his life. Apparently he was found by one of the janitors that came to clean his office. And he was at his desk, dressed in his white coat, and he was gone. And there was a note on the desk that said, "I am tired." And I remember us as a class being shocked by that. And at one of the lectures, one of the brave souls raised his hand and said to our professor, like, "How did it happen? Why did it happen?" And I remember how her face turned red, and she almost yelled at us to say, "It's a shame. He stained his white coat, he stained his occupation, he stained his colleagues and this institution." So there were lots of other suicides that I've encountered in my life, but this one stood out because it made me realize that level of shame and stigma that we encounter as professionals. And I think COVID-19 really made it very vivid that we as a community need to change in order to be more aware and more sensitive to the needs of those that are holding that front line. It's something that in a lot of ways is a systemic issue, but like I said, as an individual, I want to start with offering this talk and creating a safe space where we can be real about it. So as you see, I barely made it beyond the first slide, but I thought this disclosure is important. And I'm sure people that are present here have their own stories that they can share. And I encourage you to, again, if you want to share, use that chat to do it. Okay, Janet, I have a bit of an issue moving through and again, that my slides could be frozen. Give me 1 second. I'm going to stop the share and restart it again, because apparently it is freezing on my end. All right, let me see if it works this time. Okay, give me 1 second. I might just share it not at the full screen mode, but at the different mode, so it can be more, so I can move it. Okay, perfect. So we've talked already about our occupation being very unique, and I want to start with this opening statement from AMA that says, as physicians, acknowledging distress in our colleagues and ourselves can be difficult. We want to believe that we can handle any problem that comes our way. But the reality is, being a doctor can be difficult. And there are many stressors that we face on a daily basis: heavy workloads, lack of autonomy, high patient and self-expectations, and personal responsibility for life-threatening situations. A distressed colleague may not ask for help, but that doesn't mean it isn't wanted or needed. And I like that statement because it sets a tone, and I hope It creates a community of support and inclusion where seeking help is something that's accepted, something that's normal, something that is encouraged. And as we are talking about those unique stressors that we are facing as professionals, I want you guys to think about what is it that is the biggest challenge that you face in your occupation, and how do you think you're coping? And again, you can use the chat for that. I would love to hear from you. And there could be questions that you wouldn't feel comfortable answering in the chat, but at least you start thinking about them. I couldn't start to talk about suicide without a little bit of a statistic here. And, you know, I want to give a disclosure that statistics these days is really based on the numbers that is reported. And knowing the stigma around this topic, I have a lot of doubts that the numbers that are reported are true to the fact. So I've tried to look at some of the latest reports out there, and Medscape's physician suicide report that was reflecting on the numbers of the last year is really found that 1 in 10 physicians considered or attempted suicide, with fairly similar percentage between men and women. Now, I want to say that if we're looking at the rates among physicians comparing to other, for general population, obviously they are much higher. I also want to say if you look at the male versus female, male are about 40% higher than in general population, and female, believe it or not, is about 130% higher than in general population. The occupations within medical enterprise that are especially kind of vulnerable: pathology. That comes my example about my pathology professor, 13%, general surgery, 12%, oncology, 12% as well, infectious diseases, 11%, and emergency medicine, 11%. 24% of our colleagues said that they had clinical depression, which is really, you know, constitutes the severe depression that didn't stem from normal grief event. But among the same cohort, 64 said that they had colloquial depression, such as feeling down, blue, or sad. So think about those numbers. And again, we're looking at them with a bit of a grain of salt, because we know numbers that are reported are not necessarily reflecting the reality. And I also want you to look at this little statements that I have from our colleagues about not really experiencing joy in what they are doing, right? Being tired. Again, that goes back to my example of my pathology professor, being profoundly tired. Another piece of it, you know, that pressure of being perfect. And, you know, if you are short than perfect, then you're not good enough to wear that white coat. Now, we're talking about practicing physicians, but what's going on in them trying to seek help? Because we obviously see that this issue is acute, and, you know, something got to be done about it. And it's really sad that, again, we've created a culture where seeking help is not what we do. As physicians, we identify low rates of help-seeking behaviors, even when we are stressed. There was a study that was done in 2008, and they surveyed the surgeons, and 1 in 16 admitted to suicidal ideation in the past year, but only 1 in 4 sought professional help. And on this slide, you can see some of the questions that they were asking and responses that they got. And again, going back to data, it's surprising how much, you know, gaps we have in this data. Though we know that physicians are more vulnerable to suicide, and that trend has been going, believe it or not, since about 19th century. There are records that demonstrate that physicians have been in the risk group. However, up to this date, we shy, even in the research, to look at those facts. So that's why you'll see some of the data that may be not as recent on my slides, because if you want to dive deeper, there's really a few studies that you can look at. Now let's look at the medical trainees, and I hope we have some people here who are in that category, whether you're intern or resident. And though, again, by the data, it says that medical trainee suicide is relatively rare. However, it's #1 cause of death in male residents and #2 cause of death for female residents. And again, you can see some numbers on the slides and the graph on how that all corresponds. There was a study that was done by ACGME across 9,900 programs, and that was a study that took over 4 years, from 2000 to 2014. And the highest risk of suicide was in the intern year, with the temporal pattern in the first quarter and the third quarter. So something to keep in mind, and I hope we also have some people that are in the teaching capacity here. We need to watch our interns. We need to pay specific attention to where they are emotional. Maybe we need to create more safe spaces for debriefing for them, so they can process those thoughts and feelings that entering the reality of the occupation creates. There was another study done in 2015 with the resident physicians, and those studies has found 15.8 increase in depressive symptoms during the first year of residency across all specialties. And it's interesting statistics, because when our kids, well, I call them kids, but when our young professionals enter medical school, and typically the range of ages is around 24, 25, you know, they demonstrate a bit lower levels of depression, anxiety, comparing to their peers in the same kind of graduate studies situation. However, within the first year, this changes quite a bit. And as you see, the numbers are increasing. And then over the course of training, now we see 20.9% to 43.2% of residents report depressive symptoms, with symptoms increasing over time. So this is a disturbing statistics. And I think the question comes, why aren't we talking about it? Why is it still that big elephant in the room? There's a wonderful book that was written by Michael Smyers, and it's called Why Physicians Die by Suicide. So what he did, he actually tried to look at an interview, not just physicians themselves, but also the families and others who cared. And some of the responses that he got really correspond with what I said earlier about stigma and that culture of fear that somehow is created in our enterprise. You know, you see some of the responses here from our colleagues that said, I'm afraid that if I spoke to a therapist, I would have to report receiving psychiatric treatment to credentialing or licensing board. It's very real fear. And being a therapist, I hear those concerns all the time. And confidentiality and who's going to see my records and all this stuff really is the first questions that people ask when they want to work with mental health professionals. There is another kind of stem of concerns that come from this belief that somehow we are superhumans and we got to figure it all out all by ourselves. And again, that's a dangerous zone, because we are conditioned to be those heroes. those white knights in a shiny armor of our white coat that saved the world and saved the lives of our patients. And yet no one sees what's going on the reverse side of that white coat. And then another piece to it is really not feeling like it will be appropriate, that then if I seek help, I'm gonna appear like I failed. I'm not good enough. There is something wrong with me. How can I be this bright and the best? And yet I have this issue. So I think as we are talking about those concerns and trying to make them real, I also want to talk about humanity, peace. It is an occupation that seemed to be missing because Dr. Myers in his book talks a little bit about why physicians that actually complete suicide choose to die very often at their workplace, in their offices, and why do they typically wear the white coat. And I think what he found was that our identity as a physician really overrides any other identities that we have. And for some, it's really a logical place to end their journey and a logical way to end their journey, being true to their identity. For some, it is kind of showing the system middle finger, pardon my language, because, that's what it did to me. For some, it is something that it just feels comfortable because majority of our time we spend where? At our workplace. And that's what feels comfortable. And you don't want your family members to find you at home. You rather do it outside of the home. So some interesting stuff there. I really encourage you to read this book if you're interested in the topic. But I also want to show a little poem that comes from a doctor, Rita Agarwal. And she is an anesthesiologist, and she was inspired to write it as a response to some of the struggles that her husband went through. He was distinguished teacher, professor. He was also a practicing physician. And when he got sick and started having some health issues, she saw a tremendous negative response from his administration, from his colleagues. And she tried to reflect that in this poem. So the name of it is You Need Help, but Not From Us. And I think it's a very true statement that sometimes, somehow, on a systemic level, it is believed that if you have a problem, you gotta fix it by yourself, because that would create a burden on the system if we try to intervene. I'm not saying it's true for our enterprise. In fact, I want to say that I am forever grateful for being at GW, because I see amazing efforts from Dean Bass and her team to really focus on wellness for our medical trainees and our physicians. But I just want you to look at those lines in the poem, and perhaps a few of them stood out for you, and perhaps a few of them you actually heard yourself. So if you want to reflect on it in the chat, please feel free to do so. I would appreciate to hear it. I also see we have some people using the chat and commenting and wanting a copy of the PowerPoint, and of course we're going to provide it to you. All right, so moving on, I want to talk a little bit about some unique stressors that we face in our occupation. And again, perhaps a few of you already identified them, but like 4 major causes of stress injury in healthcare workers are right in front of you: life threat, grief injury, moral injury, and fatigue injury. And again, if you feel comfortable, I would invite you to comment in the chat if you feel that, one or two of them really stand out for you, or is really a pressing issue right now for you personally, or you're in your department and you're trying to comprehend what can be done to address it. And again, if you look at those different stressors that our physicians face, some of them are acute and some of them are chronic. And it is believed when the stressor is kind of known and expected, which very often, is not the case at all in a medical profession, then it's easier for us to handle it. If the stressor is bigger than us, if the stressor is something that is hard for us to comprehend and endure, and it is prolonged, you're in it for not just for days, you're there in months and months and months, then that's much harder to tolerate. And again, COVID-19 showed us the level of that stress that has been rising. And though right now it seems like we have pandemic somewhat under control, that chronic stress that built up over the past 2.5 years is now creating what we call mental health pandemic, where people are coming out with all this anxiety and depression symptoms. We're seeing ADHD on the rise in our kids. We're seeing all sorts of very concerning dynamics, including increasing substance use, which is also something that not foreign to how people try to cope with the stress. And
Gloria.
yes.
I'd like to direct your attention to John Smith's comment. You might want to share it with the group.
Yes, absolutely. All right, many of these are consistent with regular everyday life as a physician. One trainee told me that serving in the army under live fire was less stressful than medical school and residency. Thank you so much, John, for bringing that up. And I completely agree. I mean, there are number of occupations that have a pretty high stress level and pretty high kind of being on your toes, being ready for unexpected, and being able to react component. And it's good to remember as we are trying to see a bigger picture or reframe some of the negative thoughts that are tend to percolate in our mind when we are drugged into a dark corner by depressive symptoms or anxiety or whatever else has been contributing to, you feeling that, emotionally you might not be in the right place. So it's a very valid point. And it's good also to share with our trainees as they're entering occupation to help them see bigger picture. But since we kind of started talking about some underlying factors that lead to suicide, I want to stress that suicide is more likely to occur when there are multiple risk factors that are piling up, and most importantly, unaddressed mental health issues. Because suicide is kind of a culmination of those depressive symptoms going unaddressed, going suppressed, and then we have suicide as a result. That could be triggered by some other events, that could be situational, that could be environmental, but again, the underlying cause of it would be most likely unaddressed mental health concerns. And again, depression and anxiety are most common one, but there is also trauma that we rarely talk about. And physicians face all sorts of traumas, not just physical, but emotional trauma every day, multiple times a day. And it leaves a mark. And if you don't have a way to debrief, if you don't have a process or a ritual that lets you transition from where you work to where you rest and recharge, that can create another extra stress element. I also want to say that unfortunately, and we've touched on it, that physicians that are, dying by suicide are less likely have been receiving mental health treatment compared to non-physicians who die by suicide, even though the rates of depression are equivalent in both groups. And I also want to touch on the burnout a bit here because it's such a big topic, and we really address it a lot of times through so many talks that we do within medical enterprise. Burnout in itself, though it has a lot of negative outcomes, has not been shown to be an independent risk factor for suicide. And again, this statement may provoke a lot of questions, but again, I want you to remember, I'm going to pull up this comparative chart here, major depressive episode and burnout. And if you look at them both, they have a lot of similar symptoms on both ends. What differs them is that with the major depression, you really have a persistent course of the symptoms that are not tied to like a specific occupational situation. It's not just happening related to work, it's happening in a lot of other situations. It's kind of chronic and persistent type of a feeling. Where with burnout, it really correlates with your workload, and many people with some changes in the job environment, at the workplace, feel improvement of the symptoms. So again, coming back to that mental illness factor that is underneath of what we see, it's very important to keep it in mind as we are trying to work with the suicide as a phenomena that is increasing in our medical enterprise. And the solution to it would be at least to create a culture where seeking help is, something that is encouraged, and something that you as a person also give yourself permission to do. Because at the end of the day, it starts with permission, right? So I often find with a lot of us in the healthcare occupation that permission is very hard to give, and yet it's essential step to be able to receive help and feel better. Now, if you look at the warning signs of depression and suicide, then there are a couple of them that I want you to look at here on the slides. And if I group them, you can look at the behavior of a person. You can look at how they talk, how they express themselves verbally, what kind of language they are using, and what type of mood, and what do you see in terms of the presentation in the emotional arena. And that feeling of hopelessness and helplessness is very often first signs that you see. Withdrawal and loneliness. I want to go back to the words that my dad told me a long time ago. It gets lonely out there. And again, in our culture, we very often view our colleagues or our system as a system of competition, not as a system of support. And that's not helping us to address the issue at hand. Looking at your sleep pattern is very important, and how your mood fluctuates through the day. Are you getting irritable? Are you snapping at your colleagues and patient without no reason, or without apparent reason? Are you trying to find that escape in alcohol, or perhaps some drugs? Are you contemplating, okay, what would it be like if I'm not here? Would anyone miss me? Does my life make sense? Does it have a purpose? Or maybe my purpose needs to be redefined. Feeling trapped. Those are some of the things that are very common that people experience when they are getting into that headspace. However, there are things that serve as our protective factors. And I want to focus on them a little bit, because that's what helps us to pull ourselves out from that dark corner. And I want you to look at this picture on the slide. this mirror, huge mirror with how you doing sign. It's actually something that was posted in Hong Kong in the time of the pandemic. And this is how some of the government officials were trying to show people that they are concerned about their well-being, because again, that depression, anxiety, isolation became so prevalent that people were going into emotional breakdowns. So your protective factors are both internal and external. And there's benefit in looking at what seemed to work for you, because sometimes, people tend to gravitate toward external factors, like maybe our family supports. Maybe you have trusted group of friends or colleagues that you talk to on a regular basis. Maybe it's your therapist if you have one. Maybe there are some educational event like this one that you're trying to attend to gain more understanding about what's going on. And again, that could be one route, but internal factors are very important too, because they're not dependent on any environmental factors or changes that are happening in, from the outside. And your level of self-control, your level of frustration tolerance, optimism, positive coping skills, those are things that can help you in the long run. I've mentioned that our culture, instills that fear that if I seek help or if I tell someone, then there would be consequences for my license, for my career, for my ability to wear that white coat, right? But you can either lead by fear or you can lead by hope. So I hope that sense of hope and finding hope building practices for yourself and your colleagues would be something that can be your anchor. Spirituality, I cannot minimize, you cannot minimize the effect of spirituality. It's a huge factor for a lot of people. Knowing that there is a power bigger than themselves and there is a bigger purpose sometimes can be a game changer. Being future oriented, having responsibility to family, children, pets, all of it is hugely important. And it also helps to build your resiliency. And I want to show you this bucket of resiliency that I love to use in most of my talks. And it demonstrates that when we are stressed, we can imagine our stress handling capacity in the form of a bucket. And each of us have a different size depending on our genetics, vulnerability, risk factors. But then daily stress comes in, and then day is over, your bucket is full. And what do? And then another day brings other stressors. So if you don't have a tap to let the stress out, the stress will be building up. And again, there are some positive coping things that you can be using. And from that survey that Medscape did on the group of physicians, people mention some of these factors like spending time with family and friends, doing activities, hobbies that you enjoy, exercising, getting enough sleep, very essential, eating healthy. So those seem to be the top things that people use as their bucket emptying mechanism. So I encourage you to look at those things and see what's working for you, or maybe you have something that is different from what I have here. And if you would like to share with your colleagues in the chat, I would really appreciate that and would be curious to know. So how can we help if we have colleague in distress? I'm not gonna show this video today, but I've included a link here that has a video that was put together especially for medical trainees, but can be applied, for seasoned physicians as well, that talks about some ways to help. And what you'll see, and I want to show you this suicide continuum. When you are talking to your colleagues, you may see them at any point of that continuum. And of course, the earlier we intervene, the better. But it can go anywhere from I'm stressed, I wish I could get away from my problems, to being I'm very overwhelmed, it might be better if I weren't around, to I am not sure I can continue. I've thought about ending my own life. And it could be at the point of thoughts at that point, but it's definitely where you have that red flag raised. Because it's a very fine line between thinking that and then going to the side of, okay, well, if I were to do it, how would I do it? Oh, I am ready because I've reached the end of my rope and I intend to do that. And again, if we are talking about this continuum and having a person that have underlying mental health concerns that were not addressed, high stress and burnout, we have some maybe environmental factors, family factors that affecting that person, you know, it's really a very delicate balance that can be shifted to the side of no return very easily. So one thing that I'm going to say as a helping professional, that starting the conversation with someone that you see is not being in a good place emotionally can be really hard. And I have some good conversation starters for you here. And there is a link on the slide that can lead you to more. But it can start simply with questions like, I've noticed you've been down lately. What's going on? Or it seems like you haven't been yourself. Do you want to talk about it? Or I'm worried about you. Let me know if you would like to talk. I would love to help. So, or simply stating, I want you to know I'm here for you. I care and I want to help. Sometimes those things go a long way because again, it gets lonely in our occupation. And the further you go in your career, sometimes the lonelier it gets. So being able to start the conversation when you see someone struggling could open up unexpected emotional vulnerability in that person. And I want to state very clearly that research demonstrates over and over again that asking about suicide does not increase the risk of suicide. I want you to remember that. So asking directly communicates that you're open to talk about it. And again, the key here in a non-judgmental and supportive way, because again, we've talked about our culture being very competitive, sometimes based on fear. But if you open it up with a statement that, hey, look, I'm your colleague, I see something is off, I'm here for you, let's talk about it. Have you thought about, have you contemplated suicide? Have you had thoughts about ending your life? And being able to listen without judgment or dismissing or giving some cliche answers like, you shouldn't be thinking that way, or you're stronger than that, that's never helpful. So just opening up that space can go a long way. And when you listen, look at those things on the continuum that I showed you earlier. Is there a method of plan? So there is a difference between just thinking about it to actually thinking how you're going to do it. Are there any steps that that person is taking towards acting on the thoughts? Is there access to lethal means? And again, I'm sorry to say, we work in the hospitals. There are tons of options there that can be used as those lethal means. So, and encouraging to seek help is another thing that we can do, in addition to listening and providing that non-judgmental open space. So reassuring that seeking treatment is something that is possible logistically. It's also can be confidential. It is something that can be safe and effective for the person. And it also benefited a lot of people before. That's why I said in the beginning, I want to create that community here that can talk and can share that support, because knowing that you're not alone and knowing that there are other people that could feel that way is a huge life-changing factor that could really make a difference for a person that feels trapped. So debating whether suicide is right or wrong never helps. Trying to argue, threaten, raise your voice never helps. Being calm, open, patient is something that is needed in conversations like that. And following up. Now, one thing I'm going to say, since we've talked about how delicate that line between person actually having the thoughts to having a plan and then perhaps acting on it, I want to talk to you about high-risk situations and what could help to keep that person away from harms. Staying with them and making sure that the person is in a private and secure place. And it could be with you or with some other caring person, and don't leave them alone until you connect them with help. Making sure they're not objects that can be harmful and used in the attempt. Involving experts or local professionals that can step in and help. And as you know, as we always say, if this is a crisis situation, then you can take them to ED or call 911 if the danger to self and others seem imminent. And I want to say that there are some very specific resources that exist nationally for suicide and crisis. Recently, we have 988 Suicide and Crisis Lifeline that has been launched instead of a very long and complicated number that you were supposed to call before. So calling 988, and this is 24/7, very easily accessible line for support. And there are some resources for physicians who are having suicidal thoughts, and I put them right here so you can have it. And again, you'll have a copy of the slides available to you. Of course, GW has internal resources, and again, we have life-threatening emergencies on campus line. We have GW Colonial Health Center that also has counseling and psychological services. We have care team that you can reach to. And we also have Resiliency and Well-being Center that I and Dr. Norris, Ashley Drapeau and Janet Rodriguez represent here. And we are not necessarily a kind of a crisis type of a center, but what we do provide one-on-one counseling. We do provide help for groups, departments to address some of the issues related to burnout, well-being of their staff, emotional debriefing, and a lot of other different things. And you can see here on this slide that we also have Care for the Caregiver program that I would love to encourage you to explore. More information is on our website, but that can help to train people within your department to provide that frontline peer support to peers in distress, which we know by research works as access point beautifully in situations like this. Talkspace, Headspace, all those resources are available for our medical trainees, for our staff and faculty for free. So I encourage you to use them for your own wellness and improving your resiliency. We also have Office of Integrative Medicine that has wonderful programs like mindfulness experience, calming breaths, mindfulness-based stress reduction. So those are things that are not necessarily, good for crisis, but they are good as preventive measures as a part of your self-care that I hope after this conversation you will dedicate more time to. And again, for Resiliency and Well-being Center, we look at well-being from a whole health approach. So we're trying to address all elements in this whole health wheel to help you to be in a better place, not just emotionally, but also physically, spiritually. And that's something that I think is very unique, because most practitioners that work with us are integrative in their approach. And here on my slide, I have contact information for all of us here. And our group is pretty much represented on the panel today, which I hope you'll take advantage of. So with that said, I'm gonna pause. And I'm going to see if people have questions for me and my colleagues. Like I said, I have Dr. Lorenzo Norris, who is a psychiatrist and our medical director, and also chief wellness officer for the School of Medicine and Health Sciences. I also have Ashley Drapeau here, who's our PA, and Janet Rodriguez, who is our wonderful administrative director. So, I mean, we are here. I hope that what I've shared was informative, and we would love to open it up to questions. Or Dr. Norris, if you want to add a few things to what I said, please do so.
Can everyone hear me?
Yes.
Okay, great. I do not have anything to add. I just want to thank you so very much, Viktoriya, for this wonderful presentation, and I hope it has stimulated thought and discussion. And I just really want to hear from those that are in attendance, questions that they have, or thoughts or things in this safe space that they wish to talk about or reflect on.
Thank you so much, Dr. Norris. And I'm also seeing some...
We have two questions.
Yes.
From the chat. The first question is, could you please comment on the impact on faculty and medical system leadership and on students when these sad events occur, and how they should seek support? Thank you.
That's an excellent question. I'm not sure if it would be better for me to answer, or Dr. Norris, since you represent some of the kind of systemic
Sure.
things.
Sure, absolutely.
All
right, it's an excellent question, and a very important one. The effect on all of us in the medical enterprise is a sense of incredibly severe loss, regardless of whether it is at our institution or other institutions or places across the country. It is extreme loss. It can also be confusion. With some, we can have our own conflicts can arise in regards to our roles in terms of like our professional and personal lives. But also what it will also clearly do, which we have seen, is that it will actually not cause, but it will also, for those that have been having suicidal thoughts, certainly with a completed suicide, this can be a point of something where people start to reflect or become more attentive to in their own life. So overall loss, sadness, as well as activation of strong emotions, all of us, whether you are aware of it or not, ways in which you can seek assistance. Many of those have already been discussed by Viktoriya, but certainly you can reach out to members of the, do a consult with the Resiliency and Well-being Center. If you are currently have a mental health professional that you work with, I encourage folks to discuss it with that person. We also have our Caring for the Caregivers, if you will, champions. And I think that just starting a discussion or a conversation with your colleagues, something just as simple as like, how do you feel about that? How is that affecting you? This really, even just saying something that really hurt and me when I heard this. Starting these conversations and that peer work, as well as building up the things that we already have in place in the medical enterprise, can be a huge benefit. But it's a sense of profound loss and increased strong emotions, including potentially suicidal thoughts.
The second question is, thank you for your presentation. With regard to burnout and external drivers, what creative initiatives does the Wellbeing Center have going to intervene around external drivers of burnout for physicians, residents, and what are the outcome metrics you look at to measure success?
Okay, I'll field that one. A great question. Some of the things that we are doing right now with Resiliency and Wellbeing Center, we're just coming into really our second year. For external drivers, what you're trying to do at that point in time, you're trying to do policy interventions, really. What can you do at a system level in terms of whether it is how we set our own goals? For instance, we were working with, if you will, leadership in regards to having a staff well-being goal as part of their actual goal objectives. How do you actually look at workflows and structures of different groups, and how can we actually change things so that we are having better effective workflows? We can collaborate with that. But really one of the biggest things that you can do in regards to external drivers, if you will, in a system is actually working with middle management or leaders in regards to their communication, recognition practices, and how they work with folks. So if you look at the evidence base, that can really be a very big driver in regards to external factors. If you focus initially on, there's a lot of data on this, but you can focus on middle management, if you will, but also you have to have it built into your policies. One of the first things you have to do is actually have well-being as something that is viewed as important, that is a goal that we all recognize, and that's what we're working with in the Resiliency and Wellbeing Center. It's interesting that they asked in terms of, a colleague asked in regards to metrics. We recently just completed our first ever well-being survey, which I hope that people took part in. That will actually give us baseline data in which we can, among many other ways, where we can start to look at metrics. Surveys are one thing, but in addition to that, we have to hear directly from people when we're doing consults. We would also want to supplement survey work with select focus groups. And if you look at the literature, probably the sweet spot in terms of surveying a medical enterprise is once a year annually because of the survey fatigue. But there are other ways in terms of leadership, surveying leadership, doing select focus groups where we continue to collect qualitative data. And please fill out the feedback from this, but these are all different ways in which we would collect data. But I'm giving you the initial things in regards to the first steps in regards to addressing external drivers. The literature shows that this process, depending on where you are at, I'm using colleagues at Mayo Clinic as an example, it takes years, but we've started that process. So great question.
Follow up on that one is, which survey did you use?
We used our own constructed survey that was tailored to, it was created by colleagues Lee Frame and another, our associate researcher, Patrick Core. So we used our own homegrown, if you will, survey that was gleaned from best practices that would be applicable to the GW medical enterprise.
But I also want to mention that our own survey was actually constructed based on a few existing ones. I think one was WHO5 that is widely used globally. So we've tried to pull from best practices, globally.
Okay. Apologies also in our behavioral health director, Viktoriya Karakcheyeva, was clearly, definitively, as all of us, but a key person in regards to the survey design. So yes, thank you.
I think we have a few more questions there. All right. Well, I see people saying they will be more attentive to their own feelings and burnout symptoms and more aware of coworkers and colleagues' symptoms. Thank you so much, Paola. That's a great way. This is what I hoped for as a result of this presentation, a better self-awareness. And also, like I said, creating in ourselves that permission to focus on our well-being and seek help when we truly need help. So thank you so much. Spiritual care, I see someone mentioned that. That's awesome. And again, there are so many dimensions, and I hope that this presentation would be a beginning of the dialogue that dives deeper. We are here to assist you individually and you collectively. So like Janet mentioned, we go into departments, we create safe spaces where those conversations go into deeper and more meaningful, I think, explorations, and hopefully finding solutions. All right.
Yes, and Viktoriya, I wanted to thank you again in regards to everything that you have discussed. One other quick point, I don't want to, and I'll swing it back to you to end. When people asked me earlier in regards to the effect of suicide, I do not wish to imply that a completed suicide causes people to have suicidal thoughts. What I would like to say, though, is that what it can certainly cause is for all of us together to reflect on and think about our own views in regards to suicide. All right, so I'm not saying that a completed suicide in and of itself would cause suicidal thoughts. I just wanted to clarify that, but it certainly does make all of us reflective on our own views on suicide. So just wanted to add that.
Thank you so much, Dr. Norris. That's a very helpful and important point. I want to say in conclusion that the mantra physician heal thyself would be, I think, a good point to end, because though we are healers in our hearts and in what we do, we need to focus on ourselves so we can be that best instrument of healing to others. So take care of yourself. And I will stop here and wish you all a great day and that focus on self-care moving forward.